Thank you so much for having us. We're excited to be here today and talk to you a little bit about SBIRT for uh, perinatal SUD. And Dr. Coker, thank you for an amazing presentation and starting the conversation a little bit about substance misuse um, with maternal populations. So, as we know, Arkansas has the highest maternal mortality rate in the US. In the March of Dimes report, we know that the maternal mortality review found 23% of maternal deaths involved behavioral health complications, including substance misuse and overdose. Um, it's really important for us to be asking questions and screening for substances because we know that substance use during pregnancy and postpartum, it increases the risk of overdose, morbidity, and mortality. It can also increase NICU admissions, low birth rate, preterm deliveries, and maternal hemorrhage. So lots of reasons why we need to be talking about substance use with our moms. Next slide. Okay. This is the same legislative report that was just shown, but on this slide, we pulled this data because we're looking at current circumstances surrounding death and pregnancy-related deaths, and you could see on the far right of your screen, if you look at substance use disorders, 22% of them were involved. And so I think that's something for us to be aware of as we're starting to talk about and think about substance misuse with moms. Okay. Um, so one of the things that we're seeing, and the research is telling us, after delivery, we could see increased use. And so it's really important for us to be aware of increased use after delivery, especially after breastfeeding and or our mom's breastfeeding and drinking alcohol. Postpartum women with depression are significantly more likely to engage in risky substance use. And so if we could start the conversations, if we could ask early, if we could have those trusting relationships where patients, moms, or excuse me, moms feel that they can talk to us about this, we're going to be able to work with them and provide some education and interventions right away. We talked a little bit about not everyone feels comfortable treating a high-risk population. And so if pregnant moms are using substances, that can be tricky. So I'm very grateful for the UAMS program and the provider hotline and all of the services they provide. One of the things we also see an increased risk of overdose and suicide deaths between 6 to 12 months postpartum. So that's something for us to be aware of. We also know that there could be a link between substance misuse and increased rate of suicide attempts. So that's important for us to be aware of. And then the last piece on this slide that we'll talk about is high relapse rates among women with past SUD, or excuse me, substance misuse during the postpartum period. And that could be due to increased stressors, right? And so we know things such as sleep deprivation, they might be in pain. We know hormones are fluctuating and there's often mood instability. It can be a really stressful time in the home when we have a new baby. And so mom's stressed, but also people in the home are stressed. And if this was a coping mechanism in the past, we might see a relapse in use. Next slide. Okay. So we're going to talk a little bit about what is SBIRT. But first, we just want to say that SBIRT, which is screening, brief intervention, and referral to treatment, this is it's been found to identify and treat perinatal substance use disorder. We can see improved outcomes for moms and babies, and we see approval of this from ACOG, the Association of Maternal and Child Mental Health Programs, National Association of State and Alcohol Drug Abuse Directors. And so just important to know there is a lot of national support, and SAMHSA is supportive of using this type of screening model with pregnant and postpartum moms. Next slide. Okay, so SBIRT is screening, brief intervention, and referral to treatment. And so the literature is telling us, and we're seeing more and more, universal screening is important. And so universal screening means screening at every visit. And the reason, and when I talk about this, I think screening at every visit is so important because sometimes people may not feel comfortable telling you today about substance misuse, or when they're filling out their screener, they might not feel comfortable putting down, you know, yes, I've been having a few drinks or whatever it is. But it's important for us to know that if we're screening at every visit, we'll be able to identify, and then we'll be able to provide that education in that brief intervention or get them to the treatment they need. Next slide. One of the things that we know using this evidence-based model of screening, brief intervention, and referring to treatment is we see a reduction in drinking days by 19%. We also see a reduction in substance misuse. And you could see by these statistics, it's pretty significant. 35% decrease in heavy drinking. 43% and a 75% in illicit drug use. Next slide. Okay, there are multiple validated screeners that are being used. We just put the most frequent up here. We don't have time to go through all of these. But one of the things that is important for screeners is we know oftentimes if we give someone a self-administered screener, we're seeing that they're more, and they're self-reporting, we see more honest answers. Sometimes it can be challenging to give that information in an interview type situation. And so self-reported screeners, we see the highest rates of honesty and accuracy. Next slide. Okay, so how does screening work? One of the things that we know, similar to the decision tree that we saw earlier, is if we are screening and there's no substance use, really we can provide some education and prevent the onset of substance misuse or use at all. If we're screening and there's moderate risk, a brief intervention is important, and it'll prevent that disease from progressing. High risk, we really need to address that immediately. We need to get someone to treatment. We need to use some of the resources that Dr. Coker just talked about. The UAMS line, get them over to the care they need so that we can get that addressed. One of the things that is really, I want to stress, and I don't know if we have this in our slides, but no amount of use is safe use. And so that's why it's absolutely critical that in this prenatal in perinatal stages that we're using universal screening, we're providing education, and we're about no amount of use is safe use. One of the things that we also know, and I think is so important, is it's really critical that when we get our screening responses, we have safe, open, trusting areas for people to talk about. This is what I'm struggling with, and what are the resources out there that are available for me? So, with that, we'll go to the next slide. Okay. And am I turning it over to you now, Caitlin?
This is your last slide.
My last slide. Okay. And so I just talked a little bit about screening, universal screening again. We know it's important that we are asking at every visit. We know the most common misused substances in pregnant women are alcohol and tobacco. And so, and we see an increase in marijuana usage. And so, oftentimes, when I am talking to someone looking at screener results, um, sometimes, people will say, no, not using, and I'll specifically call out, does that include marijuana? Okay, we talked about no safe level of use. We really need to have that trusting relationship where people feel comfortable. Motivational interviewing is really a very effective technique that can help with developing that plan and getting people to the type of treatment that they want. And so, with that, I'm going to turn it over to you, Caitlin.
Sure. And I'm glad that you point out and get a little bit more specific when the screeners are done. Because if you think about it too, this could be a cultural or generational thing. They may not have any education that tobacco use in pregnancy is not safe or alcohol use in pregnancy is not safe. But you don't want to discount the health literacy portion of that and making sure you go through and just really clarify, are we using any marijuana? Are we using these specific substances can be very helpful to the conversation. I'm glad you brought that up. So, one of the most important parts of this whole discussion, though, when you're meeting with a patient in any specialty, but meeting with a patient has to include shared decision making as a part of that process. What we know about motivational interviewing, and we do trainings on that as well. And one of my favorite things to bring up there is that if a patient does not hear themselves argue for change, they're most likely not going to do it, right? Like we know that if we make the most convincing argument to change our behavior, we're going to feel a little bit more connected to that goal as opposed to our doctor giving us a goal and saying, go forth and conquer. I think this would be the best for your health, right? So traditionally, and I say traditionally, this is many years ago, we have transitioned to more of a bidirectional patient-centered view now. But we had that kind of, I'm the doctor, here's the education, this is what I think you should do for your health. We've now are transitioning and included in SBIRT a more educational perspective that allows empowerment to happen. So they can not only make those changes that were discussed, but they can replicate these skills for other things that they may need for other behavior changes. So at the end of the day, these goals are value based for that patient and they're patient centric at the end of the day. So that last part of the acronym for SBIRT is going to be referral to treatment. And it's not as simple as it sounds, right? It's not just about putting an order in an Epic and sending it on its way and scheduling to call the patient later. There's a couple of other things that go into this portion of the acronym. So just like Dr. Coker was talking about and Kim was talking about, you want to make sure you match the patient to the right type of treatment based on severity and resources. So I'm sure that many of us have patients and are aware of patients that obviously live in rural settings. They drive several hours to come and see their practitioners. So resources for them as far as any kind of even outpatient substance use treatment or inpatient is probably going to be pretty limited in their own community. So being aware of some barriers that might happen should you refer this patient out for treatment. That might need to be part of the conversation, whether it's you or your care coordinator or your nursing staff or whoever has the manpower and the time to sit down and have these discussions and not just what will your insurance cover and what are you realistically able to do right now, but also how will you get there and what about your job and what about your other children, etc. So making sure that that's part of the conversation. But the gold standard for any referral but especially for substance use, is going to be that warm handoff whenever possible. Um, either as the practitioner or the nursing staff, whoever's able to do it. What we like to see with SBIRT, specifically what they suggest with this model, is that you sit down with the patient and the professional you're referring them to and have a three-way conversation with them about what this patient may need, what the goals and concerns are. We have seen a significant increase in treatment engagement when a referral is done this way. And if you think about it very like plainly, you're really like borrowing the trust of the provider, right? So being pregnant and talking about substance use is a very vulnerable time for someone, and they felt safe enough to have that conversation with you, and now they have to go outside your office depending on that severity and transfer that trust over to that other office, and it's so much more helpful when that provider's on the phone or a member of that care team's on the phone, because there's a lot of trust infused in that process. So if that's a possibility, utilizing something like peer support, utilizing a care coordinator to help facilitate that change. And then finally, there's always the question, what do I do if this patient doesn't want to make any change? Kim and everybody else on the call, I'm sure, has the same mindset of no use, like no level of use is safe. But there's also one of those things where we can only do so much, and do as much as the patient allows us to do, right? So there's always that part of the conversation of, what if they're not ready for change? What if they're only ready to sit in your office that day and receive that psychoeducation? Okay, so we want to make sure we reaffirm their autonomy and provide them with harm reduction guidance, and make sure we schedule a follow-up very closely to that appointment with them, just to touch base and check in on with them. When are you ready to make that change? So we know that there's a lot of things going on in this process, and we wanted to give just a quick glance at basically what the SBIRT journey can look like for your patient going through the office or going through that screening process. So the journey begins with screening. They're identified as high risk or mid-risk, and then that brief intervention is applied depending on their need. And if needed, that referral to treatment happens. But regardless on if that referral to treatment or that intervention is done in-house, you always want to schedule that follow-up care within a week, right? So typically when we prescribe a behavior change, we give them a little bit longer to meet those objectives and work on those goals. But with something like substance use, where it has ample possibility to go wrong at any moment, we want to make sure that we're keeping mom and baby safe, and that means pretty rapid follow-up, pretty frequent follow-up as their insurance and as their schedule allows. Okay. Now, Kim and I have been in healthcare a long time and have worked with systems and in primary care clinics, et cetera. So we know that implementation of new workflows and change does not happen without funding, being realistic. So yes, you can get paid for these screeners and for these interventions. There's a lot we could talk about with this this topic here. So I'm just going to show you this chart. It might be helpful to take a picture of it. But we've got those CPT codes up for commercial insurance and Medicaid. But there is also a booklet that CMS has put out that will include some more information. And I obviously don't have time to go through the hyperlink right now, but if you plug in CMS Healthcare Code Sets ICD-10 fact sheet, that'll come up. And I'm absolutely certain your billers and coders have heard of that booklet. So they may already have that resource, but that is available for you to review as well. Okay, so implementation of SBIRT or implementation of mental health can look different for every system. It really depends on what your resources are and what your capacity and what your community is able to do at the moment. So here are some options for implementing SBIRT or screeners or just buffing up that support system that you have in your area. One of those things is building partnerships between that OBGYN and SUD provider, right? So let's say as a provider, you know that there are clinicians in your area that are providing substance use disorder treatment, but you've never had a conversation with them. Maybe we make a point in the new year that's just around the corner and say, I would love to have at least conversations with 2 of these providers so I can know where I'm sending my patients and we can have a more streamlined referral process. Advocating for statewide training for care teams that touch base with our maternal population, that's family medicine, OBGYN, pediatrics, I had the privilege of interviewing our board president, who's a pediatrician, about a year ago, and he talked about how he's also paying attention to mom while he's in the room seeing the kiddo, and he will screen mom as well if it seems like she might need some extra services too. And I just felt like it was really comforting to know that our counterparts in other specialties are also helping on that continuum as well. Sharing any educational resource you come across, collaborating with substance use agencies, and then supporting policy and funding for SBIRT expansion. Having those conversations when appropriate and with who's appropriate, with your state agencies, and talking about, we have this problem, how do we solve it? And then finally, some options that are going on in other states. There are programs right now that implement plans of safe care. I do know of one in Colorado where basically the health system partnered with the state's DHS system and are working hand in hand with them when a mother is identified as high risk or having substance use disorder. They work with the case managers at the state level to help make sure that the home is stable, and it has decreased the need to remove the child from the home. They have seen some pretty good success with that. And then tracking screening rates, because the only way we make change is being able to provide data. And then focusing on our high risk areas, rural, low access. We have plenty of that here in Arkansas for sure. So at the end of the day, I know we went through this fast, but at the end of the day, we're saying if you start a conversation about this, you will save a life. Don't discount how important and how influential asking a question of substance use disorder can be at a routine appointment, right? Or having those early and compassionate conversations with patients increases trust, and it opens the door for opportunity for all kinds of treatment should that patient be willing. So that then reduces that risk for mom and babies. It helps that family that's at home thrive. And it really encourages those evidence-based solutions to be continuously used in these settings and replicated in other specialties as well. And that is the end of our presentation.